Dear colleagues, I am Dr Hemraj Chandalia, and today I am going to speak on young diabetics and how they are different from the usual type of diabetes that we see. Young diabetes is defined presently as diabetes starting after the 20 years age. Between 20 and 35 is the limit for the young diabetics. And the most common cause of diabetes at that time is actually still type 2 diabetes, especially close to 30, 35 years. You can see a good number of patients which are falling into type 2 diabetes group, and they are to be dealt with as we usually deal with type 2 diabetes. However, there is also possibility of type 1 diabetes at this age. And if you see all young diabetics, both of them almost equally about 40%. And of course, these are some of the very rare diabetes which are seen at this young age, that is fibrocalculous pancreatic diabetes, is a very interesting diabetes called Flatbush diabetes and mitochondrial diabetes. Type 2 diabetes at young age, of course, is from 20 to 35 years of age. And according to recent national survey for non-communicable diseases, it was found that diabetes prevalence in population at large in India stood at about 9.3%. And this is in 2018. And this group that we are discussing today, 20 to 35, in that particular group, the prevalence was obviously less than at the whole adult life, and that was 5.5% increased to about 7.7%. So this is figure about every 9% diabetes in the adult. Similar estimates have been given by International Diabetes Federation, where diabetes prevalence was estimated as 9.6 in 2021 and projected to increase to 10.4. All those projections you see very often in many lectures. Now, another possibility when you see the person at that age with diabetes is, of course, type 1 diabetes. And of course, it presents some with very typical clinical features which will help you diagnose that. And that is very likely their onset itself will be heralded by the episode of ketoacidosis. And biochemically, what clinches the issue is that you do a C-peptide level associated with high blood glucose, that is a sort of stimulated C-peptide. And if that is less than 0.6 nanogram per ml, then it is very likely to be type 1 diabetes. And sometimes in them it is as low as 0.1 or 0.2 nanogram per ml. Usually these individuals are normal weight and they have the presence of autoimmune markers. And there are 2 or 3 common antibodies that we look at. That is, one is anti-glutamic acid decarboxylase, that is GAD antibody. Then you have anti-islet cell antibodies, ICA, and anti-insulin antibodies, IAA. So all these are 3 types. Any 2 out of these GAD should be done, and 1 out of the other 2 is completely diagnosed, and that positivity is completely diagnostic of type 1 diabetes. It can present rather rapidly, a very, very fast onset, and weight loss can be quite severe, like even a couple of kilos per week. Polyphagia, all those classic features are there, which may be absent in type 2 diabetes. And weakness, fatigue, cramps in legs, and of course, with such high sugars emerging suddenly, there are genital fungal infections and with producing balanitis and vaginitis. Then another important group there is called maturity onset diabetes of young, or MODY, very popularly known as MODY. And MODY is often an autosomal dominant disease. And very rarely, of course, it is mitochondrial, but usually autosomal dominant, and it divided into subtypes, many different types, MODY 1 to MODY 14, which are a little bit different etiology and sometimes a different presentation and the natural history of the disease as well. So MODY is often misdiagnosed as either sometimes type 1, it is in very young people, and often can be in very young people like 15, 20 even, and often misdiagnosed as type 2 diabetes as well. So between those two, sometimes they are mistreated for quite some time until you realize that there is very strong family history of diabetes. You will find in 3 generations, which the child's parents and grandparents, if you inquire carefully, you'll find at least 2 or 3 people there having diabetes. So that history is very important. And once you get that, you should seriously think of MODY. And of course, nowadays we do the genetic studies as well. And there, of course, you do the whole exome study and you'll be able to diagnose which kind of MODY it is. And of course, if you are in doubt, you do the C-peptide and you also do the autoimmune markers. And these will be, C-peptide will be here normal and autoimmune markers will be absent. MODY 3 is one of the commonest MODY and it is progressive hyperglycemia. But the vascular complications are not as much, or in fact, almost not described. So this is very interesting. You can have long-standing hyperglycemia going on without complications. In all other MODYs, there is a possibility of vascular complications as well. And these individuals, especially the type 3 MODY, you can treat by lifestyle modification, low carbohydrate diet, and of course, in many of them, sulfonylureas are preferred treatment of pharmacotherapy and they are very effective. So I have had many children of this type who were started on insulin, and as soon as I saw them, the clinical features were different. So we did genetic study and proved that it was MODY, and of course I shifted them to sulfonylureas. And for many years I've seen them now. They are doing quite well on simple sulfonylureas like glycoside, plain glycoside, 20 to 40 milligram, 2 or 3 times a day. They come under excellent control. The pregnant diabetes with MODY may require insulin therapy during pregnancy. The same children growing further and pregnancy is undertaken, then you may need insulin there. So this is typical of MODY. And of course, another very interesting feature and type of disease which is seen in this young age is what is called latent autoimmune diabetes in adults, LADA we call it. And this is present, you see, is 6.5% of cases. Mind you, in type 2 diabetics at large also, if you really screen for autoantibodies, some of them are positive. And these are the type 2 diabetes who slowly progress into almost type 1. Otherwise, we know that type 1 and type 2 are different and they don't cross each other. But this one can be initially diagnosed type 2 until it transits into type 1. Slowly the C-peptide falls and insulin needs emerges, and you realize the person is not only requiring insulin but insulin dependent. Then you know that this is LADA. Some additional features of LADA is that the age is usually more than 30 years. Sometimes they can be much older and they misdiagnose their type 2 diabetes and treated. And then they may have additional history in the family or in themselves, say, of autoimmune disorder. For example, they can have autoimmune thyroiditis. So thyroid antibodies, if you do, they will be often positive in them. And that shows their propensity to have autoimmune disorders in general, which of course includes LADA also. LADA patients also are not as much overweight or they don't exhibit the typical features of metabolic syndrome like obesity and lipid problem and all those. And you see the BMI is lower and they usually don't have hypertension or other comorbidities, and HDL cholesterol is normal as compared with type 2 diabetes. C-peptide diabetes level decrease progressively in this and move towards type 1 diabetes, and there is GAD antibodies which are long-lasting antibodies. The other antibodies may come and may also diminish as you go along and disappear, but GAD antibodies may be present in these people. So that may be the best antibody test to do. And initially they will not require insulin for quite some time. They can be treated like type 2, but subsequently they will require or they will depend on insulin. The other type of diabetes seen in the young is called fibrocalcific pancreatic diabetes, which was found to be more common about 2-3 decades ago, but is getting rarer and rarer as we go along because it probably had some origin in some toxic foods being consumed or something of that type, which have never worked out very conclusively. So you don't see as much FCPD, certainly not in the Maharashtra area, but in the south of India, originally described in Kerala, a large number of patients, it may still be on, but the incidence is going down. There are no recent figures on the incidence of FCPD at the present time. And of course, FCPD may respond to oral drugs, but with bad malnutrition sometimes you like to introduce insulin therapy in these youngsters. And of course, it starts at early age, and there will be pancreatic calculite, abdominal pain, and there may be also exocrine pancreatic deficiency producing indigestion and increased stool fat excretion and diarrhea. So there is high susceptibility to pancreatic disease in them, and this is probably also an inherited as well as some environmental toxins which work to produce this kind of diabetes. The last very interesting diabetes in the young is called Flatbush diabetes. This is not much seen in India, very cases here and there described. These are young people with obesity. So this is one category of young diabetics who are obese. They present with ketosis. So they almost look like insulin dependent or type 1 diabetes with very high sugars. But you treat initial period and thereafter not only you are able to remove insulin, but they will not require any additional hypoglycemic therapy as well. And subsequently, they can be treated by a good lifestyle intervention of diet and exercise and weight loss. So this is one type of, again, diabetes you see of young, and initially seen as ketosis prone, but subsequently they stabilize and there is no tendency to ketoacidosis thereafter. So I think with these descriptions, I have given you ideas about a variety of diabetes you can think of when you see a young patient with diabetes, obviously very young, probably 12, 15 years age, you very much think of type 1. As you go along, the other possibilities are also there, type 2, MODY, and all those emerge. So keep your mind open regarding the diagnosis when you see a patient in this category. Think for a while, do some tests like say peptide or autoantibodies, and look at the features that are described for you, and you will be able to classify correctly, and that will make a lot of difference in the treatment that you give them. So important to diagnose this. Thank you very much for your patient listening.